And I wanted to talk through, I appreciate that this audience probably has quite specialist skill sets, very interested in rehabilitation, but to look a bit more broadly at our work and some of the concepts of why we do what we do and how we do it. And then Maria is going to follow on with talking more specifically about one of our projects. So very briefly, and I appreciate that you're all probably very much aware of this, in talking about our work and the reasons why we do what we do, who do we actually consider to be people with disabilities, the participants of our research? We work under a definition from the United Nations Conventions on the Rights of Persons with Disabilities, which I won't read out in its entirety, but effectively looks at disability as an interaction between the individual's intrinsic limitation in functioning, be that their physical functioning, visual functioning, etc., and also the factors external to the individual that can either create barriers or facilitators to access. So as an example, a person with a physical impairment caused by any number of particular conditions, the impact of the access they may or may not have to an assistive device or to inclusive services on their overall lived experience. I hope that makes sense. Given that that's our definition of disability, why we think it's important to measure disability, and again I appreciate probably talking to a lot of people who have their own answers to this question, some of which Professor Chamberlain already mentioned in her introduction. We have several global estimates of disability with certain numbers that are kind of bandied about quite a lot. We have the World Health Survey and the Global Burden of Disease, but these global numbers, which tend to estimate about 10 to 15% of the global population as having a disability, actually come from quite unclear indicators. Often it's indicators of either health loss or of particular conditions, which are then extrapolated to come up with indicators for disability, which are not actually accurate. Again, Professor Chamberlain mentioned the World Report on Disability, which was a joint collaborative project between the WHO and the World Bank that came out in 2011 and really pulled together a lot of the existing information that we had on disability, and really quite strongly came to the conclusion that there is a massive gap in the evidence that exists on disability globally, especially in low and middle income countries. This is echoed by the United Nations Convention, which also expressly talks about the need to build up a robust and comparable evidence base, with data needed sort of really most urgently, most importantly, on elements such as the prevalence of disability and within that particular impairments, be that physical, visual, cognitive, etc., the magnitude and the impact of impairment and disability on the individual's lived experience. At the most basic level, we need better statistics at both the country and the global level, people living with disabilities, and we need these so that we can plan appropriate services, and I imagine that's what's probably most interesting to a lot of you, is without having the data on the number of people in need of a particular service, especially in a limited resource setting, you really don't have very much information to start moving forward on how best to spend those limited resources. And on a wider level, of course, there's the need for data so as to be able to provide the evidence base for advocacy, to be able to leverage for inclusive services, equality of opportunity, etc. Those of us working in the disability sector and disability research internationally, I think, have been very much frustrated over the last sort of few years or decades, even probably before I even started, that there seemed to be a lack of global interest in gathering information on disability. So the 2015, the Millennium Development Goals talk about a lot of important statistics and indicators, goals, etc., but none of those include any mention of disability. So really at the moment we're in a situation where there is this growing momentum. The post-2015 agenda is quite important. There have been high-level meetings at the UN about this. UNICEF released their first ever State of the World's Children that looked at children with disabilities as its main component. And DFID have just set out an inquiry into inclusive development and disability. So there's a lot of things happening at the moment that are quite exciting, that are helping us to push forward. And I know that one of the things that one of the reasons behind this evening tonight is to look at some of the challenges and the difficulties in conducting this type of research. So I think in particular at the moment we've got a good opportunity to start moving forward and to be looking more for grants and opportunities. So I wanted to very briefly, before I started talking a bit about some of the projects that I've done, and how we have looked at measuring disability overseas to look at the different service needs of people with disabilities. And I'll go through this quite quickly because I imagine this audience is probably very much aware of the type of gaps in service provision for people with disabilities, generally speaking. Primarily in terms of medical services, before moving on to rehabilitation, which is, I appreciate, the focus for a lot of you, we also know that in a lot of situations, people with disabilities actually have lower access to general healthcare, so to primary healthcare in terms of, for example, here you've got immunisations or maternal health, and that people with disabilities can often be quite marginalised from those services. Similarly, people with particular impairments may have need for specialist medical services, and there's often a large gap there between which services are available or accessible, affordable, and even just knowledge about what services are available. So, for example, surgeries to correct cleft lips or palates, surgeries to correct vision, Ponseti treatments for clubfoot, etc. Low-cost assistive devices, which can have quite profound positive impact on especially children growing up with particular impairments. There's very limited information about what devices are available and in what contexts. Both of those examples there are of assistive devices to assist in physical functioning, but of course that also includes devices such as hearing aids to aid hearing impairment, or braille, white canes, etc. for visual impairment. Further specialist sort of examination and medical services, we don't have a lot of information about what's available in particular settings. Often we do appreciate that services are very limited, especially as you get to more rural situations, but we don't have a lot of data on what exists and how it can best be procured for people in need of them. And as those of you probably, I don't know, I meant to ask actually at the beginning if any of you had actually worked in an international setting working in rehabilitation services, but I imagine I see a few nods that some people have. Obviously, there is often a very limited availability of rehabilitative services such as physiotherapy, speech language, neurocognitive rehabilitation, etc. And community-based rehabilitation services. So again, I'm not sure how many of you are familiar with community-based rehabilitation. But I see again lots of nodding. So understanding what services exist, where the gaps are, and what the need is in terms of rehabilitation, not just physical rehabilitation at the community level, but also social inclusion and decreasing stigmas and barriers, particularly in terms of education as well. Community outreach services, so this is obviously very similar, there's a lot of overlap there with community-based rehabilitation, but looking at the training of community members, informants and health workers that can provide more of a service at the community level and link up people and children with disabilities with health services that may be geographically more distant or more difficult to acquire. And finally, awareness raising. So in the sort of most basic sense of actually decreasing a lot of those stigmas, I think all of us working in countries or living in countries like the UK or in Europe, we're used to disability being, I mean, not entirely included, but it's a lot less stigmatized. You find some really quite traditional, really quite uncomfortable stigmas that remain and can be quite profound in a lot of the countries that we work in. So given the sort of really wide range of different service needs that are out there, a lot of the gaps, the evidence that we don't have, I think the simplest sort of approach that you may consider in terms of identifying people with disabilities and understanding what their needs are would be to actually monitor the amount of people that present at a particular service. But of course, that is very, very caveated. That doesn't really include the or rather that doesn't take account of the fact in a lot of these situations those services simply do not exist. So if you stand in a rural part of the world and you're wanting to find out how many people have a particular service need, if those services don't exist in the first place, it's very hard to be able to gauge those estimates. There are also a large number of barriers that can limit people, both with disabilities and people generally, from accessing services. So in general terms, a service may exist, a rehabilitative service, a specialist medical service, etc., but it may be geographically very difficult for the person to attend. In a lot of countries there aren't national healthcare schemes that can provide the funding for particular services. And for people with disabilities in particular, there are additional stigmas relating to disability. We often come across, for example, gender issues, so you may find that there is a child with a disability in a particular setting. The mother or primary caregiver may be absolutely desperate for that child to attend a particular service that they've been referred to, but for particular reasons in the household dynamics, there may be other members of the household who do not sanction that. The time use burden, again, in certain situations, if there's a mother or primary caregiver with a number of children that she is responsible for, the ability or lack thereof to actually take a particular child to a particular service that may be some time away. And then, yes, more generally, sort of the natural political environments that can make it very difficult for people to access services, particularly if they have particular impairments. So, for example, there may be a hospital at a particular point miles away, but if you don't have the assistive devices or the mobility to be able to get there, that can cause a real challenge. So then I wanted to move on, sort of saying if that's the grand picture, if those are the type of services that are that we need to understand whether people with disabilities can or can't access them, and we know that there are some real challenges in terms of identifying who those people are. I wanted to talk through a little bit some examples of the type of methods that we've used at the International Centre for Evidence in Disability to identify people with with disabilities and link them up to appropriate services as exist. So the first approach that I want to give an example about is using an actual survey method, looking at population-based surveys where we identify a representative sample from a study population and screen and assess for disability to be able to extrapolate to the country level and provide robust estimates. So this example, and I only have really just a few sort of slides on each one to sort of give you the overall gist of the studies. We can talk about them in more detail in the question times if anybody wants to raise specific questions. This is a big study that we're currently undertaking. We've just finished the data collection in Cameroon last summer, looking at screening people for disability, people of all ages, for a number of different types of impairments and disability. As a population-based survey, we have an enumeration of clusters, segmented clusters that have been randomised via the population frame, and all people of all ages who screen positive for a particular impairment are referred to follow up if needed. In this particular study, in terms of the appropriate follow-up or access to services, we worked in partnership with a local hospital that was funded internationally. It was an NGO hospital and provided the services, the requisite services needed for individuals, alongside a community-based rehabilitation program that was operational in the area and undertook to follow up all people with disabilities that were identified. Alongside, I'll talk a bit more about the measurement, the measures that we used and how we actually measured and defined disability in this study, but alongside the population-based survey, we also took a nested case control study of people with and without disabilities from the communities to be able to understand if there was any difference in terms of access to particular services, to education, in the access to livelihoods, health and antenatal care, etc. We identified people within the study population, a sample of all ages, who were brought to a central village location for screening by a mixed medical team. So each individual of all ages had their eyes tested using a Snellen chart to test visual acuity, their ears tested using a two-stage methodology of otoacoustic emission testing of the ears, first to check middle ear function. For anybody who failed that, there was pure tone audiometry to look at the impairment in hearing. For physical impairment, we used a tool called the Rapid Assessment of Musculoskeletal Impairment, which again, I don't know if there's physiotherapists in the audience who are aware of it. It was developed by members of our group for use in Rwanda in 2008. And we used two reported screens, a self-reported screen of functional limitation, developed by the Washington City Group at the World Bank. And for those aged 18 and above, we also had reported clinical depression screen. So each member of the study sample population of all ages, with the exception of the clinical screen, which was for 18 years and above, was screened using all of these different methods. And anybody who screened positive via any of those methods was then further examined by a medical professional. So we had 3 teams, each including an ophthalmic nurse, a physiotherapist, and an ENT specialist, to be able to provide examinations, diagnoses, and referrals. There are certain challenges in terms of conducting population-based surveys, in terms of the practical logistics of doing a study like this. Disability is relatively low prevalence. As I said, the global measures that we have tend to say 10 to 15% of a total population. So consequently, you do need to have quite large sample sizes in any given study if you want to have statistically valid and powerful results. Obviously, this is then quite expensive, and it can be quite lengthy to conduct a population-based survey. For example, in Cameroon, the 4,500 people took over 3 months of 3 teams working 6 days a week to screen them all. Equally, it's resource intensive, particularly the type of method that I just went through. We are looking at, in Cameroon as the example, we needed to have 3 ENT specialists, 3 ophthalmic nurses and 3 physiotherapists who were available for that 3-month time period, which I think people could rightly say is draining a very limited resource even further by actually engaging technicians and clinicians in this type of work. It also misses children in particular settings, and children and adults who, because of stigma or because of shame, are not actually openly included in the sort of the household roster. So you can have a situation that when you go to enumerate a household to take part in the study, that the caregiver or the household respondent may not actually identify this particular person because of these issues of stigma. So given that, I hope I'm doing okay for time. I'll try and be a bit quick. I've only got a couple more slides. I wanted to briefly go through an alternative method that we've used in the past to look at identification of disability that is cognizant of the issues that you have there with population-based surveys. So I haven't actually named it as such, but this is the key informant method that was referred to on the flyer and before by Professor Chamberlain. The key informant method is a community-based approach which looks at training non-medical, non-professional community members to identify, in this particular setting, children with various impairment types. It was initially validated to look at children with visual impairments in Bangladesh. I think it's also been used to look at children with epilepsy in India and in visual impairment in a few other countries. This study was looking at whether or not key informants could be used to identify children with either physical impairments, visual impairments, hearing impairments, or epilepsy. So key informants are identified based on their community capital, working with community chiefs and using social mapping to identify those who are going to have the greatest opportunity to identify children with disabilities in their communities. It's far less costly. This particular project came out at about 10 times less to identify a child using this method than using a survey method, with all resources kind of combined. And it is more useful in terms of finding more hard to reach children. And when you have stigma, if you've got somebody who's based within that community, they're more likely to be able to identify the children living within that community than if you were to have an enumerator come in for a 1 to 2 day enumeration. In this particular study, we had all children who were identified by a key informant as potentially having the impairment types. And in the interest of time, I won't go into the training, but there was a standardized training package that the key informants received on how to identify these children, what they were looking for. Each child who was then identified was examined by a full medical team with diagnoses and referrals made as needed. In this particular study in Bangladesh, we trained 1,500 community key informants who between them listed just over 4,000 children that they suspected as having the targeted impairments type. We also undertook a household survey of 8,000 children so as to be able to do that comparison, to be able to understand whether or not key informants were able to identify the same numbers of children and what the cost differences might be. We mapped referral services in each district, so this is unlike the situation in Cameroon where we had one particular NGO hospital that we were partnering with. We were very lucky that this hospital had a lot of different services. In Bangladesh, it was more a system of mapping remote and more different services that were available and actually trying to link all of those together. And I think I'll put the slide in later. I'll show you a little bit more about the mapping. I won't go through all of the measurement techniques that we used, but again, I can come back to this later if anybody's interested. Very similar to in Cameroon. So once the children were brought to the medical assessment camps, they were screened for impairment using these standardized measures. And this slide, again, I don't know how easy it is to see from the back, but this is an example of the type of referral network. So these are the impairment types that we were interested in, that we were expecting to target and identify, and services that were available in the different geographical areas and the different services that they provided. And probably better for the discussion, but I'm happy to talk a bit more about what worked and what didn't work about that process. But I don't want to overrun Maria's time. So very quickly to finish up, just in case anybody's interested, the findings of this study. On the left-hand column there, this is the prevalence estimation using the key informant approach. And on the right-hand side, the prevalence estimation using the household survey. And we found that actually the key informants were able to identify the same numbers of children as the household survey at a much lower cost for all the impairment types we were interested in, with the exception of hearing impairment. The key informants, the children identified by key informants, the prevalence estimate that we have is 0.3 per 1,000 children with a bilateral moderate or severe hearing impairment, versus 6.4 per 1,000 using the household approach, which is obviously really very significantly different, the non-overlapping confidence intervals. And there are a number of reasons for that, which again I can go into if anybody's particularly interested. Otherwise, for the other impairment types, we found that there was a very strong rationale for using the key informant method. And I also wanted to pick up on, so within that, the overall prevalence of childhood disability that we found in that study was 9.0 per 1,000. And of those, not far off half, 3.7 per 1,000, were children with cerebral palsy. And I wanted to mention that specifically because one of the situations, one of the issues that we had in Bangladesh was that services for children with cerebral palsy were very much lacking. They were essentially non-existent in the areas that we were working in. And Maria is going to talk a bit more about the sort of solution to that and the parent-led training manual that she developed to try and overcome this gap. We had from that cohort over 2,000 children who were referred to specialist services with follow-up provided by the key informants. And what's quite useful from this database is we now have the records of which children were referred to which services, which can really help in terms of trying to estimate, sort of extrapolating upwards sort of per million children, for example, what services are needed. All of that information is in the main report for this study, which is available from our website. So just to try and summarise then, I think what I hope I did get across was that the measurement of disability is quite convoluted. There are different methodologies that are appropriate in different settings, and it is something that is very important for a number of reasons. I imagine those of you as clinicians see the service delivery element, but as I tried to explain, obviously there's other services that are important as well, and that the correct option on how you do it is very different depending on variables. Most importantly, I think, including what your incentive is, what the rationale is for the data collection, and what the resources are that are available.